welcome to the Grand Rounds. And before we go to the actual today's proceedings, I just want to remind everyone that this weekend, the coming weekend, we're going to have a special session on amyloid cardiac imaging. It's a conference where you're able to come and learn about the nitty-gritties of imaging. So please avail of this opportunity. This is going to happen in the school at the Patterson Street in the auditorium between 8 o'clock to 12 o'clock. And I also wanted to remind you that this month we have got an opportunity to do cardiology and cardiac surgery combined grand rounds. And Michael Mack, who is vice chair of the NHLPI cardiothoracic network and a very well-known personality in valvular heart disease interventions and surgeries, is going to come and speak on the cardiovascular collaboratory, which is a new initiative from the FDA. And he's going to come and be in person for the grand round. So please make sure that you disseminate the information and avail of the opportunity to be part of this occasion as well. For today's grand rounds,
Gupta, the slides are not being shared.
Okay, so I'm going to just go ahead and try to do it one more time. Share screen. Are you able to see now?
Yes.
Okay, so I'm just trying to. How about now? Is it coming?
Yes.
Okay, great. For today's grand rounds, the CME, please text 17010 to 888-816-4893. 17010 to number 888-816-4893 as an SMS message so that you can avail of the CME credits. And also, if you're interested for the maintenance of certificate points, please complete the step 1, the CME, and this link, which will also be displayed again in the chat box, will have a room code future 36 with which you can answer the questions. And if you answer them correctly, you get the ABIM MOC credit directly into your Cloud CME profile. And now for today's grand rounds, we're going to have Dr. Jonathan Weinsaft talk to us about a very important paradigm of tissue characterization. But before I go there, I want to welcome him. Jonathan, welcome. It's a great privilege and honor for us to be together today in this meeting. I'm going to introduce Jonathan. Dr. Weinsaft is Antonio Mgoro Professor in Atherosclerosis and Lipid Research at Weill Cornell Medical College, New York. He's Professor of Medicine in both cardiology and radiology. He has been a thought leader in the space of tissue characterization in multimodality imaging, specifically in magnetic resonance imaging. His mentorship and leadership is well known. He has mentored over 100 trainees over the past 2 decades. He has been a mentor for the NIH K23 and AHA Career Development Grant Awards. He co-directs the Cornell Cardiovascular T32 Fellowship Program and is currently the director of the Non-Invasive Cardiac Imaging Program at Weill Cornell. He's the director of the Cornell Nuclear Cardiology Program, Magnetic Resonance Program, and also the director of the Memorial Sloan Kettering Cardiac Magnetic Resonance Imaging Program. He's extensively funded from multiple NIH grants. 7 of them are currently active. He has played a very important role in bringing up the field of multimodality imaging, particularly magnetic resonance imaging, and has several appointments at professional societies in SCMR, ACC, NIH, and the National Marfan Foundation. He serves on multiple high-impact journal editorial boards and is extremely sought internationally and nationally for his work, and he has presented at several occasions. He has nearly 200 peer-reviewed articles, editorials, chapters, and guideline documents. And his area of work is centered initially on cardiac magnetic resonance tissue characterization of cardiac thrombus, and specifically inversion technique that was pioneered by his work is now widely used in tissue characterization of cardiac masses. In addition to this, he has also other areas of interest, specifically in ischemic mitral regurgitation and its pathogenesis. He has worked also on aortic imaging and has recently been focusing on submillimeter vessel characterization to inform the risk stratification and therapy of aortic aneurysm repair. But most importantly, I think you all will recognize once I'm also going to introduce the panel. Joining with Jonathan is our panelist, and that is Dr. Sabahat Bukhari and AJ Shah. This is an extremely talented group of individuals. Actually, I would call them, they are magnetic in their personalities and the work that they have done. But more importantly, they are excellent and very, very good to work with. One of the best human beings I have come across. That really magnifies the importance of the of getting to know them and working closely with them. So I'm really looking forward to see this opportunity further translate into several collaborations, and we can continue to have bridging conversations and insightful dialogues as the time continues. So with that, Jonathan, I'm going to bring you to the main podium and have you share your slides, and welcome.
Thank you so much, Dr. Sengupta, and thank you, Dr. Bukhari, and really all of you for joining me today. First off, are my slides projecting?
Yes.
Okay, perfect.
Yes.
First off, thank you very much to really all of you for joining me today. Thank you for the invitation to speak at Cardiology Grand Rounds at Robert Wood Johnson Rutgers, and thank you for the opportunity to really learn about the wonderful and dynamic program that is being developed at Rutgers, which really is a leader both nationally and internationally in the cardiology space. I'm going to be speaking today about CMR tissue characterization for neoplasm and thrombus, really rethinking imaging paradigms for diagnosis, therapeutics, and prognostic risk stratification. Here are my disclosures. I've been paid speaking fees by GE Healthcare and have done additional consulting not related to this presentation. So first, a definition of terms. What is cardiac MRI? Well, it turns out that unlike virtually every other test in cardiovascular imaging, CMR can be many different tools really folded into one modality. By simply altering the order and the structure in which we apply radiofrequency pulses to the heart, we can get very different sorts of information in terms of how the heart is functioning, and what cardiovascular anatomy is. We can assess cardiovascular structure and function. We can assess flow gradients. We can give contrast and assess ischemia as well as cardiovascular anatomy. But what I would pose to you is that if that were all that cardiac MRI could do, the explosive growth in this mortality that we've seen over the past 2 decades would not have occurred. Because many of these techniques that I've described earlier can be provided by other modalities. Certainly, echo is great for assessing cardiovascular remodeling, cardiovascular function and flow. We can assess perfusion using radionuclide techniques, and certainly CT is fantastic for assessment of cardiovascular anatomy. But what sets CMR apart is its ability to provide that information while also linking these changes in terms of structure and function of the heart to underlying changes in myocardial tissue properties. It's the ability to understand tissue characteristics, which allows us to predict response to therapy, as well as prognosis, and that is especially important for assessment of cardiac masses, which is going to be the focus of my talk today. So why use CMR for assessment of cardiovascular masses? Well, certainly it can provide dynamic functional assessment. It can provide multiplanar imaging, as shown in these two examples to the right. Here we see a mass in the right ventricular apex, which is dynamically moving. In the bottom example, we can see a mass in the inferior vena cava extending up into the right atrium. And those, the ability to assess those unique planes is shown on the bottom with exquisite temporal resolution and great endocardial definition is certainly unique to CMR. But as I've shown you earlier, the uniqueness of CMR, which really sets it apart, is the ability to link that information to actual tissue properties of a given mass, whether it be a conventional T1 or T2 weighted imaging, as well as dynamics enabled by perfusion assessment. I'm going to be breaking down my talk in terms of general categories. We're going to gloss over assessment of pseudomasses, meaning normal anatomic structures, which can masquerade as pathological structures and can be delineated by MRI. I'll start out by looking at the issue of benign neoplasms, which we also often think about. And these are sort of broad diagnostic categories which one can consider. For the fellows and certainly others early in their education, certainly we know that atrial are the most common of these this category. They've been up to 50% of all cardiac neoplasms in prior case series. These are typically left-sided in location, but as we've all learned, these can vary both in terms of location and morphology. So shown on the bottom, about 80% of these are left-sided, but in about 10 to 20% of cases, these can be right-sided, or even in some cases, ventricular, as shown here. But what's interesting about these masses, and we're going to be talking about throughout the rest of our talk today, is the ability to find differences with respect to tissue properties. So typically these are T2 bright in terms of their appearance. These are fluid-containing masses. But when one looks at late gadolinium enhancement imaging, we can see that these masses classically are bright in center in terms of central vascularity with peripheral hypoenhancement. So these can vary. We can sometimes see diffuse enhancement in atrial myxomas, or sometimes we can see hyper-enhancement on the center, but lack of contrast uptake in the periphery of those masses. So, and I'll be talking to you in terms of why that might be important. Most commonly, in terms of case series of cardiac masses that we encounter, is that of thrombus, and how we assess that is linked intrinsically to tissue characterization. So I'm going to back up a little bit. I'm going to talk to you in terms of late gadolinium enhancement imaging and how we approach that in terms of a fundamental tissue characterization approach. So certainly what we know in terms of normal myocardium is that gadolinium, which is an extracellular contrast agent, has a low volume of distribution. So normal myocardium is shown on the right. We can see myocytes shown in the schematic with K representing potassium, and a small volume of distribution for gadolinium, which is an extracellular contrast agent. Now, in the setting of myocardial infarction, what we can see is that there's cellular death, whether it be acute or chronically. But the volume of distribution for gadolinium markedly increases. We see in the acute setting, there is cell death. In the chronic setting, there is collagen deposition. But what that results in is an increase in volume of distribution for gadolinium. Thrombus provides us with an inverse example. By its very nature, thrombus is avascular, meaning there's no means for which gadolinium can distribute into those masses. So whereas normal myocardium provides a low volume distribution of gadolinium, and infarction provides a high volume of distribution for gadolinium, thrombus, because it's avascular by its very nature, provides no volume of distribution for gadolinium. And this has been an area in which our group has worked for nearly 2 decades in terms of focus. Now, the traditional pulse sequence that has been used to identify myocardial infarction and myocardial enhancement is that of late gadolinium enhancement or inversion recovery imaging. And I'm showing you a schematic of this on the top of the slide. So we invert myocardium by applying a non-specific inversion pulse. We wait for a given period of time, and we then sample at a pre-specified time in which normal myocardium is nulled. Myocardial infarction, because its volume of distribution of gadolinium is increased, has a shorter T1, so it recovers earlier and is bright in areas of infarct. Thrombus, as I explained earlier, because it has effectively zero volume distribution for gadolinium, has a prolonged inversion time. And we can use that property, we can exploit that property to differentiate thrombus from normal myocardium or areas of infarct. Now, in a conventional inversion recovery pulse sequence, myocardium would appear black, infarct would appear bright, and thrombus, because the volume of distribution is prolonged, has an etched type appearance. Very early in our research, we noticed, and we really exploited the fact that we could modify the inversion recovery pulse sequence, and we could selectively sample at a point at which infarct, because it has a large volume of distribution, and normal myocardium, shown on the bottom because it has a small volume of distribution, have recovered from that inversion pulse. But thrombus, because it has no gadolinium on board, recovers more slowly. So on the top of my slide is a conventional inversion recovery pulse sequence. And on the bottom of our slide is what we call the long inversion time pulse sequence that we developed to selectively null thrombus. Now, in an initial paper by our group, we demonstrated proof of concept of the utility of that approach. So here's what we expected to see. We imaged sequential patients with impaired ejection fraction, nearly 800 patients with EF less than 50% in a single center registry at Duke. And here's what we expected to see. Typical example, low EF patients shown, thrombus on functional imaging, etched type appearance on conventional inversion recovery pulse sequence, and that uniform black, that selective nulling with long inversion time imaging corresponding to pathology findings. But here's what we also found. We also found a number of cases in which mural thrombus was identified or present in atypical areas. So on the image on the top, here's a flat area, which seems near equivalent to other areas of myocardium on our functional MRI image, not detected on echocardiography, but on selective nulling, you can see there is a flat mural thrombus adjacent to the left ventricular anterior wall, which one can distinguish solely based on that long inversion time pulse sequence. Same sort of thing here. Here's a patient with a large left ventricular aneurysm involving the inferior wall. This patient had a massive inferior wall myocardial infarction. Nothing really detected. You can't see very much on the echo, but you can see a layered mural thrombus in terms of on the long inversion time imaging. We also exploited that pulse sequence to begin looking at structural risk factors for thrombus. We found that thrombus was present in about 7% of all heart failure patients. This was in a cohort of 800 consecutive patients. But interestingly, that the presence of thrombus strongly related to etiology of cardiomyopathy. It was 5-fold higher in ischemic versus non-ischemic, strongly related as well to the presence of late gadolinium enhancement. And that late gadolinium enhancement in terms of its association with increased prevalence of LV thrombus was independent of ejection fraction. So as you can see on the slide here we've done a 3D graph in which we're stratifying based on severity of LV dysfunction and severity of hyperenhancement. And what you can see is that the presence of thrombus was linearly related to both risk factors. It wasn't just LV function alone. it was enhancement as well, providing a structural nidus for thrombus formation. And that certainly, we believe, in terms of future research that we're doing, is strongly related to embolic risk, independent of contractile dysfunction. As further proof of concept of the utility of this approach, we then tested it prospectively. And this was one of the earliest studies that we did when I transitioned back to New York. We looked prospectively at 121 patients at high risk for left ventricular thrombus due to complex coronary artery disease or advanced cardiomyopathy. And in all patients in this cohort, we applied a dedicated multimodality imaging protocol. Namely, we performed both non-contrast and contrast echo, as well as cine-CMR, functional CMR. And we did all three approaches independent of what the results of any given approach were. So every patient got both a contrast echo and a non-contrast echo, as well as a functional MRI, irrespective of what the non-contrast echo or any other test showed. And in all patients, we used late gadolinium enhancement as the reference standard. Effectively, we compared 3 anatomic imaging approaches, each of which identifies thrombus based on morphology, to the reference standard of LGE tissue characterization. Each of these modalities was read independently by a dedicated core lab, blinded to the results of the other techniques. So here's a representative example that was acquired as part of this study. Here are 2 patients imaged at Weill Cornell, independently read by the echo core lab here for LV thrombus. And I will tell you that both of these patients was read negative for thrombus by our core lab, by the director of our core lab. I would ask you which of these patients has an LV thrombus. If I had been reading this, I certainly would have read patient B. I mean, you can see that there's some swirling and there is a filling defect in the LV apex in patient B. I can understand why patient A was read as negative, but certainly one sees a filling defect in patient B. And I was surprised that they did call this negative. Suffice it to say, seems to my eye that it is there. So let's look a little bit more closely. Here's patient A again. This is a young guy, relatively young guy, presented to us with a recent myocardial infarction. You don't see much. You do see this little small area on the contrast echo. Again, you see that as well on the functional MRI, but it's moving with the rest of the wall. Function is relatively preserved. And frankly, both the functional MRI core lab as well as the echo core lab read both examples as negative. But LGE did show a focal small mural thrombus within the LV apex, and patient actually went for coronary arterial bypass surgery, and at the time thrombectomy performed based on the LGE results, confirming the tissue characterization data that we obtained. Here's patient B that is somewhat surprising. Again, you can see that area, that filling defect, as I showed you in the LV apex on the left. Again, you sort of see it on the right. Echo lab did read it as negative, somewhat surprisingly. But it is understandable based on the functional MRI, which was also read as negative. You really see some swirling, but there's no focal tissue prominence. When we look at the late gadolinium enhancement images, we can see that there is a thrombus there, but actually it's adjacent to the basal inferior wall, not in the LV apex, in which we saw that, that swirling area. When we looked at overall diagnostic performance of the techniques, we can see that anatomic imaging, whether it be non-contrast echo, contrast echo, or functional MRI, all of which identify thrombus based on morphology rather than tissue properties, demonstrated relatively suboptimal diagnostic performance. While contrast echo improved diagnostic sensitivity, it too missed about 1/3 of all thrombi identified by tissue characterization MRI, similar to that of functional MRI imaging. In short, it's not based on the modality, it's based on the approach. And the approach is the tissue characterization, namely identifying thrombus based on avascular composition, provides incremental utility. We then looked and used this approach to identify structural risk factors, both prevalence and predictors of thrombus in the current ST segment elevation MI era. We took 201 consecutive STEMI patients. Again, like the initial study design, we did non-contrast and contrast echo independent of image quality. Again, we found that nearly 10% of patients in the current reperfusion era, 8% of all patients overall, did have LV thrombus, and that the prevalence was nearly twofold higher after your anterior wall MI, strongly related to hyperenhancement, as said to you, as I showed you earlier. What's interestingly is that only 18%, less than a fifth of all patients with thrombus, had left ventricular aneurysm. So you can't rely on LV aneurysm to identify thrombus. Based on this, we then developed a diagnostic algorithm using early iterations of machine learning, as well as dynamic functional characterization of strain within the basal to mid to apical LV. What we demonstrated that was that if you use functional characterization, whether it be quantitative strain on echo or quantitative tissue tracking on CMR, you can actually stratify. We were able to actually stratify those patients in whom thrombus was most likely based on functional characteristics, and identified high-risk cohorts solely based on pattern of contractile dysfunction, showing that in patients with advanced contractile dysfunction, risk for thrombus was nearly twofold higher, and that those patients benefited from a CMR exam for identification of thrombus, irrespective of whether or not the anatomic imaging showed it or not. Does any of this matter? Absolutely. We've done a series of studies. I'll show you 2 data sets showing that thrombus identification based on tissue characterization strongly predicts risk for embolic events. Here's an early data set that I showed you earlier, the cohort of nearly 800 patients in whom we looked at embolic events among patients stratified based on LGE tissue characterization, as well as functional imaging using echo. One can see an over a 5-fold risk of embolic events among patients with LGE evidence thrombus, 15.1%, compared to 2.1% in patients without LGE evidence thrombus. But when one stratified based on echocardiography in an echo subgroup, the difference between events did not attain significance. Why is this? Both due to false negatives and false positives on behalf of echo, as I showed you earlier. We subsequently used this approach, moving beyond LV thrombus, looking at cancer patients. And this is certainly an interesting area of work. We've transitioned using the late gadolinium enhancement imaging approach to that of LV thrombus, looking more at catheter-associated thrombus. So here's a more recent study using that same sort of approach in 130 cancer patients with central venous catheters. Similar to LV thrombus, the echo data in this cohort yielded moderate sensitivity and specificity for identifying thrombus on catheter as compared to the reference of LGE CMR. And that the association between remodeling and risk for thrombus was not great. Prevalence of thrombus in this cohort was independent of right-sided structure of and function, but that if you did have a thrombus, as identified by late gadolinium enhancement imaging, you're at markedly higher risk for embolic events. Similar to the risk for stroke that I showed you with LV thrombus, the risk for pulmonary embolism in this cohort with a patient with right atrial thrombus was nearly 6-fold higher among patients with compared to those without right atrial thrombus. So moving beyond that, more recently, we are really trying to throw that algorithm into a new context. So much of what we do identifies and stratifies risk for prevalence and for risk for actual outcome in patients with risk factors for thrombus based on the presence or absence of thrombus at the time of imaging. Now that's great, but as I showed you earlier, the risk factor for thrombus is there whether or not you image a patient at the time that the thrombus is present. And it strongly is related to hyperenhancement. So now there are a number of studies, including data from our group, as well as data from collaborative studies, showing that the likelihood of embolic events in large epidemiologic population-based cohorts is related to hyperenhancement, even if a thrombus is not present. So the association between thrombus and MI is there. And the association between MI, or late gadolinium enhancement, and stroke is there. If you look at the late gadolinium, look at the Iceland MI study, as well as Cornell-specific data, even if thrombus is absent at the time of imaging. And we're now leveraging this for a large epidemiologic study that's being proposed, which stratifies, looks at risk stratification for embolic events solely based on hyperenhancement, and uses hyperenhancement as a guide proposes to use hyperenhancements as a guide to inform anticoagulant decision-making. So moving beyond thrombus, we've talked, which we've talked a lot about, certainly when one thinks about cardiac masses in general, the issue of cardiac cancers, both primary and secondary, is certainly a major concern. If one looks in terms of malignant primary cardiac neoplasms, I'm not going to speak extensively about this, but this is a small group of primary masses that we see. It's associated with extremely poor prognosis. These are angry-looking masses. These are aggressive masses. I've shown you general categories. Certainly the one or representative example of this is angiosarcoma. For the fellows, the key take-home point to message is that these are typically right-sided in locations, and these are aggressive tumors that don't respect boundaries. But when one looks in terms of large cross-sectional series, far more common than primary cardiac neoplasms is that of secondary cardiac neoplasms. If one looks at review papers, certainly here's one from the 1990s, here's what you'll read, that metastases are 20 to 40-fold more common than primary neoplasms, that they're usually associated with a poor prognosis, commonly with pericardial or pleural effusions, and I've given you some general common etiologies. Well, if I can convey one thing to you for the remainder of my talk, it's that we have learned, certainly in terms of our clinical experience and research over the past decade or so, is that CMR tissue characterization really enables new insights that have challenged existing paradigms regarding both diagnosis, clinical sequelae, and prognostic impact of these metastases. Certainly when one looks at cancer-associated metastases, there are four major modes of spread to sort of think about. We talk about transvenous extension as a major mode of spread. Certainly CMR provides value for that. I showed you this example earlier in my talk of an IVC mass coming up into the right atrium. We can see that here. For those of you savvy enough to demonstrate, to detect it, one can see that not only is there a mass here, but there is a secondary metastasis that is spread into the right pulmonary artery. So there's an example of how CMR provides value. CMR can also demonstrate direct transvenous extension via pulmonary veins into the left atrium, as shown in these two examples here. Masses can also directly invade, and CMR provides value there in terms of understanding where they are in terms of their location in the heart. Here's some examples of non-small cell lung cancers infiltrating into the posterior aspect of the left atrium. And certainly these masses can hematogenously seed as well. So here's an example of a patient that was sent to us with quote unquote new onset hypertrophic cardiomyopathy in a patient with adrenal carcinoma. If you've got a patient with suspected cardiac mass and it's a new onset hypertrophic cardiomyopathy and they've got systemic cancer, suspect a metastasis. One can see on the perfusion imaging, there's differential perfusion, and this patient turned out to have hematogenic seeding of their adrenal carcinoma. In terms of modes of spread and utility of CMR in terms of understanding these conditions, certainly when we talk about hematogenic seeding, not only does LGE provide value, but certainly there's additive value of other techniques. Here's a patient with pancreatic cancer. We can see it spreading into the right ventricle. One can see it here. It's diffusely enhancing, consistent with a neoplastic etiology. And on perfusion CMR, one can see that here. But we can also see, if one looks, there is a perfusion defect, as you can see. This patient not only turned out to have a metastasis to their right ventricle, also turned out to have, as suspected on CMR, a filling defect in their lungs, which corresponded to a pulmonary embolism that was subsequently diagnosed on CT. So perspective is everything. I've shown you that CMR can provide a broader perspective in terms of cardiac masses, cardiac thrombus, and cardiac tumors. And certainly my perspective and our perspective as a lab has been shaped over the past 15 years when we've shifted not solely to being at Weill Cornell, but also being across the street as well in terms of being at Memorial Sloan Kettering Cancer Center. The fundamental question that we certainly ask ourselves when approaching cardiac masses, is that of whether a tumor, a mass is vascular or not. Certainly, I've talked to you a lot about a lot of broad diagnostic categories, but we certainly can't establish those diagnostic categories based on an imaging test alone. And so when I think about masses, and certainly my approach has been informed over the past decade at Sloan, the fundamental question that I believe is helpful for imaging to answer is that of whether a mass is fundamentally vascular or avascular. If it's vascular, intrinsically, it is a neoplasm. Neoplasms rely on vascularity for growth. And if it's avascular, it is intrinsically thrombus or vegetation. Those are very different diagnostic considerations. And what I would pose to you today is that the fundamental value of CMR is its ability to answer this question. I talked to you about the utility of late gadolinium enhancement for identifying thrombus based on avascularity. And conversely, what I would show you is that we can use that very same approach to identify neoplasm based on presence of vascularity. Whereas thrombus is intrinsically avascular by its very design, by its very nature, neoplasm requires vascularity for tumor growth and for tumor proliferation. So here's an example of the utility of that approach. One example of a patient with two patients with right atrial masses, patient A, patient B. One can see based on functional imaging, it's near impossible to discern which has a tumor and which has a thrombus. But one looks at the tissue characterization available, provided by CMR. One can see from patient A, there's diffuse enhancement in the mass. This patient turned out to have a metastatic melanoma, which one can see in terms of contrast uptake. And patient B, there's diffuse absence of enhancement. This patient had a thrombus, which was promptly treated with anticoagulation and resolved. This has been the focus of really the past 5 to 10 years of our work in this area. And I'm going to review some of the papers, including ongoing data that we're collecting. So here's an initial paper published by our group looking at this question, 60 patients with stage 4 systemic cancer, where we simply tried to characterize A, how these patients manifest, and B, what these patients manifest in terms of ancillary finding. So we looked at 60 patients with stage 4 cancer, half of whom had enhancing masses, cardiac metastases on cardiac MRI, and half of whom did not, but had identical cancer with regard to etiology and with regard to cancer stage. What did we see? Well, first, the notion that these cancers, these metastases often occurred with cancers that were not typical for cardiac involvement. The cancers didn't read the review chapter. We saw patients with adrenal, CNS, hepatic tumors, all of which metastasized to the heart, had cardiac metastases. Second, that location was highly variable, not uniform in terms of its distribution, but that also that cancer patients with cardiac metastases didn't seem to have the classic findings. Only a quarter of them had pericardial effusions, only 50% of whom had pleural effusions. In a next study, we began to look more closely at differential tissue properties of these tumors. So here we expanded our cohort in terms of this ongoing registry. We looked at 126 patients with systemic cancers. Similar design, half of whom had cardiac masses, half of whom had a same cancer, no cardiac masses, but equivalent etiology and stage. And we differentiated the cardiac masses based on presence of enhancement or absence of enhancement. We were able to assign etiology of thrombus or tumor simply based on this. What did we demonstrate? That mortality markedly varied based on what the etiology of the mass was as defined by LGE-CMR. If the tumor was called to be a thrombus versus if the tumor was called to be a neoplasm based on LGE tissue characterization, markedly affected your prognosis, threefold higher rate of risk of death. In a subsequent study, we then looked at diagnostic approaches. So often one raises the question of how do we diagnose these? What modality should we use? Should we get a CMR? Should we get a PET exam? And how do these two things interact? So we then took our cancer registry and we went back and we said, of these patients who are getting CMR, these patients with cardiac metastases, can we better understand how CMR and PET agree, when the two do not agree, and what the implications of that disagreement is? And I would argue that of all the papers that we've written in this space, this paper has possibly the most relevant implications in terms of cancer care. So we looked at 121 patients with systemic cancer undergoing both PET and CMR within a very narrow interval. We interpreted both modalities independently, independent core labs, for presence or absence of cardiac metastases, both visually and quantitatively. And then we performed follow-up for risk assessment. So on the image on the right, this is kind of what we expected to see. Here's a patient with a cardiac mass on LGE-CMR, diffusely enhancing. We can see diffuse enhancement in terms of the FDG PET image. Here's another example of what we expected to see. Patient with a mass in the RV outflow tract, enhancement, FDG uptake on PET. But when we looked at our overall cohort, we found that the accuracy of PET was less than we had anticipated. Sensitivity was 70%, accuracy 74%, about a quarter of masses were being missed. Why might this be? When we looked more closely, we found that the sensitivity of PET strongly related with respect to the extent of avascular tissue composition on LGE-CMR. When neoplasms were diffusely enhancing, we found that there was extensive FDG uptake, great agreement. But when we found tissue necrosis, meaning small areas of enhancement within the tumor, but extensive tumor necrosis within the tumor on LGE-CMR, PET performed in an intermediate value. When there was extensive enhancement with admixed tumor necrosis, PET demonstrated it. But in masses that were predominantly avascular, with only a small amount of enhancement, as shown in this arrow on the right, PET did not detect it, which kind of makes sense. If the tissue is necrotic on CMR with only a small amount of enhancement, FDG is not going to detect it, and that's what we found. When we looked at the prognostic implications of that, we did find that whereas LGE strongly impacted prognosis, extent of LGE predicted mortality risk. Stratification based on PET, meaning FDG avidity, yielded lesser differences in mortality. Why was this? Well, in part because it was missing these non-enhancing lesions with only small amounts of enhancement. We then, in two subsequent studies, have looked at the prognostic implications of that tissue composition within cardiac masses. In an initial study, this is building on our registry, we've looked at 224 cancer patients with and without cardiac metastases, asking this question of whether non-enhancing masses or extent of tissue necrosis within a mass matters. we found that if you had a non-enhancing mass, sort of that, if you had a small amount of enhancement, if you're right-sided, strong risk of pulmonary embolism. We also found that the pattern of LGE enhancement modified your prognosis, and we're going to get more into this in the final paper I'll discuss. So when we looked based on pattern of LGE, we found that lesions with diffuse enhancement, lesions with diffuse contrast uptake, patients with and without cardiac neoplasms had similar prognosis. When one looked at heterogeneously enhancing neoplasms, neoplasms with late gadolinium enhancement, but also with tissue necrosis on the LGE CMR, one found that those patients with admixed enhancing and non-enhancing masses, lesions with tumor necrosis on the LGE CMR, strongly had worse prognosis. And that was predicted in both univariate and multivariate analysis. In the short time that I'm going to have left, I'm going to talk about some future directions, ongoing research by our lab in this space. First, we're extremely interested in the notion of using quantitative perfusion to build on the value of LGE CMR for further stratifying prognosis among patients with cardiac metastases. I showed you this example of the patient with hematogenous metastasis secondary to adrenal cancer. And I showed you how the perfusion pattern was slightly different in that area of the LGE evidence enhancement. So here's new data from our group. This is currently in review at a very prominent journal in the cardiovascular imaging space, at which Dr. Sengupta is certainly a leader. We've looked at 462 cancer patients with and without cardiac metastasis. So this is same sort of study design. And patients with cardiac masses are having the etiology established based on LGE CMR. So we are identifying thrombus versus metastasis based on the reference standard of LGE. And then we're using quantitative perfusion to look at the extent of vascularity within these cardiac metastases. We're actually quantifying the amount of contrast enhancement based on perfusion CMR. And one can demonstrate that whereas LGE CMR provides great prognostic utility for differentiating tumor versus thrombus, as I showed you earlier, fantastic in terms of its ability to identify and differentiate between broad diagnostic categories, perfusion CMR provides additive value for patients once you've established the diagnosis of a cardiac metastasis. So among patients with LGE CMR evidence cardiac neoplasms, risk for death strongly varied in proportion to magnitude of lesion hypoperfusion. So lesions with low perfusion had highest mortality. Why might that be? Well, we strongly believe that it relates, again, to this issue of tumor necrosis. Remember, I showed you earlier that necrotic lesions were less likely to be detected by PET. Necrotic lesions with evidence of tumor necrosis on LGE CMR seem to predict worse prognostic outcomes. And when you begin to quantify that with perfusion CMR, you can see very similar patterns. Among patients with lesions in the highest perfusion tertile, shown on the bottom green Kaplan-Meier plot, prognosis risk for death was very similar between patients with and without cardiac metastases. Among patients in the lowest perfusion tertile, prognosis is much different, much worse prognosis among patients in the lowest perfusion tertile compared to tumor-matched controls. And when one looks in terms of multivariate analysis, when controls for cancer etiology, anti-cancer therapy, and a variety of other factors, one can show that lesion hypoperfusion on perfusion CMR strongly impacts prognosis. Now, why is this important? When we look back at this overall cancer cohort. When we look at our prognostic data, one can see of interest that the prognostic outcomes in this group are actually not fantastic, but better than one would expect. Over 50% of this cohort was alive at 1 year post cardiac MRI assessment. This is far different than the review chapter data that I showed you earlier. These patients are living longer. These patients are doing better with anti-cancer therapies. And this is why this is incredibly important. We're beginning to move beyond broad diagnostic categories. We're getting into much more sophisticated prognostic assessment, and CMR uniquely allows us to do that. We're also very interested in terms of our lab, in terms of quantitative approaches, looking at not only quantitative perfusion, but parametric mapping for characterization of these tumors. So here's a representative example of this. This is a patient with metastatic sarcoma. This is 3 years post targeted biologic therapy. So again, longer term survivorship in these patients, and one can see in terms of quantitative parametric mapping, we're able to get pretty good assessment of lesion tumor properties of this. And we're just publishing this data, or beginning to work on publishing this data. We're also very, very focused on therapeutic response. This is that same patient that I showed you earlier. We're now up to year 4 in terms of follow-up. Obviously, the tumor is growing. But if you had said to someone early on in terms of treatment, you've got a systemic sarcoma with metastases to your heart, what's your 1 year prognosis? Certainly you wouldn't have predicted this patient would be alive and still being followed by CMR 4 years post initial diagnosis. And we're certainly seeing more and more of these cancer survivors, and that makes all of the more importance in terms of getting more sophisticated indices in terms of tissue characteristics and their prognostic implications. We're also extremely interested in our lab in moving beyond the notion of CMR as a tool for fibrosis or edema-based tissue characterization, and we're moving more into the metabolic space. Oxygenation imaging using new approaches, and I'll just touch upon this. This is a new approach developed by our group, similar to BOLD, but somewhat improved in terms of its quantitative approach. And we've validated this approach termed quantitative susceptibility mapping for assessment of oxygenation in the left and right heart. We've been supported by an R1 in terms of our area of work in this area, and we're now using this for looking at metabolic activity in cancer-associated masses. I won't go into our recommended mass protocol, but I will go into some of our some final points in terms of key points to take home. So what's the take-home message in terms of what should we remember? Certainly that cardiac MRI enables integrated anatomic, functional, and tissue characterization of cardiac masses. Anatomic and functional imaging are important, but shouldn't be relied upon for either diagnosis or prognostic risk stratification. It's really CMR tissue characterization, namely the notion of vascularity, which can differentiate neoplasm from thrombus, and this provides incredible value for stratifying prognosis. And finally, the new approaches, which we're very, very excited about, whether it be quantitative perfusion, for which I've shown you the data, which should be published in the imminent future, or parametric mapping using T1 or quantitative susceptibility, have the potential to not only assess the extent of vascularity, but also biologic activity, and thus further refine both diagnostic and prognostic assessment of these tumors. I'd like to thank certainly everyone at Robert Wood Johnson Rutgers who's invited me today. I'd also like to thank many of the members of our lab, some of whom were mentioned here, certainly many, many others, both fellows, residents, collaborators, biomedical engineers, and others who've made this work possible. Thank you again for this invitation, and thank you again to the audience for taking the time.
Thank you very much, Jonathan, for this wonderful display of technology, and certainly it's remarkable how much of the work that you have done and the future that is is coming up, particularly with the surviving cancer stories and the ability to tissue characterize. It's amazing. And I would like to also acknowledge, we did mention Dr. Anthony Altobelli, who was also instrumental in and enthusiastic in having you come and present to us. I'm now going to bring in our panelists, Dr. Bukhari and Dr. Ajay Shah. So, Sabi, please, and Ajay, would love to get your input and questions, and look forward to a discussion.
Hi, Jonathan. How are you?
How are you? Thank you so much. And thank you for this invitation. Thank you to Tony as well. And thank you for many, many times we've spent together in all of the teaching and otherwise.
It's great to see you. Great to listen to your great talk. It was excellent. Quick question, Jonathan, just your insight about it. So now you know that PET MRI is, a lot of places have started doing that. So do you think in future directions, especially looking at therapeutic response, not with just FDG, but with some other isotopes, which look at microcalcification, fibrosis, so combining that with PET and looking for therapeutic response to the masses, do you think that has any role in it?
Yeah, I actually do. We're very excited about that as well. I think it has great, certainly great potential. Further area study is needed. But if we're now beginning to understand these patients, if we can show from our cohort that 50% of these patients with cardiac metastases are alive at 1 year, you're beginning to address issues of chronic cancer survivorship. Such that why does this matter? I mean, when you look at the 50-year-old and you can say to him or her that they're going to make it to their son or daughter's high school graduation or maybe beyond, and you can inform that based on imaging, that's critical. And so I think certainly we've moved beyond anatomic descriptors. CMR tissue characterization is critical in terms of understanding diagnosis. We need to move beyond diagnosis and beyond broad categories of prognosis to understand biological activity, whether it be PET-based tracers for metabolic activity. I agree some of the newer tracers beyond FDG are critical, as well as new approaches as well. And I think hybrid imaging is very exciting.
AJ? Do you have any comments, AJ?
Yeah, I know. It was a great talk. Yeah, Dr. Weinstoft. Is this become a routine now for you? So as you showed with the delayed imaging, looking at the scar and then doing another delayed imaging to look at the thrombus. Now, has this become your routine imaging? And also, if that is the situation, now how much do you wait? So usually as we wait for the delayed, maybe depending on the nulling and whatever, 9-10 minutes. Can you tell us a little bit about that?
Sure, absolutely. So, I think, so this is a broader concept. So I think about a cardiac MRI exam very similar to the way many people think about a transesophageal echocardiogram exam. So before that patient gets into the CMR scanner, my perspective is what is the most important information that can be provided to the referring physician. And, I would say two things. When we started at Cornell, we had a rash of patients referred for CMR prior to our coming, and they would get out of the CMR exam and the information would not be provided to the referring physician. So we began to design protocols which broadly answered questions independent of what the clinical indication was, so that everybody who got into an exam had functional characterization, comprehensive late gadolinium tissue characterization, no matter what they wrote on the requisition. And the analogy that I gave would be that you don't walk into a car dealership, purchase a car, put down the money, pick up the car, and there are no wheels on the tires and no seats in the car, and the car dealer then says to you, well, you never asked for wheels, you never ever asked for a seat. So every patient who gets into a cardiac MRI scanner has to have late gadolinium enhancement and functional imaging and comprehensive valvular assessment. The second thing I think which is critical is that there's not a second that is wasted from start to finish of that CMR exam. So when we have 10 minutes of a gap period after contrast administration, our techs are extremely active. Immediately after that contrast is given, we perform phase velocity encoded imaging for both the aortic valve and pulmonic valve, such that we have valvular quantification in all patients. The second thing that we do after that contrast is given is go directly into long inversion time imaging. So virtually every heart failure patient has a long inversion time single shot approach attained. Why? Because so many of these patients with low ejection fraction will have thrombus, even though you didn't suspect it based on an echo or any other approach. That the value of CMR is it provides insights independent of what any other approach might attain. The other two components that we'll attain in all patients are, number one, an inversion time scout, and T1 mapping. And I would argue that the inversion time scout is more important than anything else, because I can't tell you but the number of patients, and I hope, Sabi, you will second this, who've come in with a diagnosis of hypertrophic cardiomyopathy and come out of the CMR exam with a diagnosis of TTR amyloid. And those are patients with, with minimal enhancement, patients not suspected based on echo or other approaches. And certainly it's a whole separate discussion. We'll take issue with some of the more recent guidelines in terms of where CMR is in that. But I think certainly any patient whom you don't know what's going on, whether it be low EF or HFpEF, there's additive value. And then obviously we'll get LGE in all patients.
Great. No, that's really, very insightful. The question also was, you showed how the echo was missing these thrombuses, and so the question is also, is there any study for the stroke patients? So clearly we look, with the TEs, maybe we missing, thrombuses even in the stroke patients. Is there any such study for the stroke patients that similar approach would have identified more patients with thrombus? Or
so a couple of things. So first, I would say there is good data, certainly using both CT as well as data using CMR for identification of left atrial appendage thrombus. There's data from Deep and Shah at Houston Methodist, which is great data. But I would argue that I would hope that in 20 years, when I'm retired and hopefully playing golf with, and done with all this, that we move beyond anticoagulant decision-making, which is predicated based on presence or absence of thrombus at the time of imaging. I think it's ridiculous. So I showed you data from our JACC study showing that we can very well stratify your risk for thrombus based on extent of hyperenhancement and magnitude of contractile dysfunction. And I would say that based on that, your risk for an embolic event is probably similar, irrespective of whether you happen to have a thrombus at the time that I happen to do a CMR exam. That if you've got a low ejection fraction patient with extensive hyperenhancement, he or she is at just as high a risk of a stroke and substantially higher risk of stroke than a low ejection fraction patient with minimal hyperenhancement. We're in the process of proposing to NIH to do that study, and we'll see where that winds up.
So, Jonathan, I'm going to ask you a little bit more provocative question. So, I think this is amazing, the amount of the work that you can do and the amount of information you can gain, and potentially this is almost like you would never need any form of histopathological tissue characterization. You could get it done, everything. However, considering the amount of burden of cardiovascular disease and the throughput challenges that we have, we need to also think about faster and more efficient scanning times. And I know that there are now AI-based sequencing and planning of the sequence based upon the early images of how you could probably modify the sequences. That's going to be potentially be able to plan the whole imaging process. But also, second point I wanted to ask you, do you think you will need to have contrast injected in every patient? I'm not saying right now, I think we need to do that. But what is the role of tissue characterization without requiring to have any contrast injected? Let's say from radiomics standpoint of view, that's an area of work that is coming up. And certainly I know that there's some work that is happening with just simple T1 based tissue characterization without requiring any contrast. I don't think we are there as yet, but do you think there is any future to that direction?
So I think that's a very, very exciting area of work. We're working a little bit with Resinezafat on an NIH protocol looking at AI-based radiomics for identification of infarct and otherwise. Certainly there's going to be a need for more technical development, and that's incredibly. I know you're doing fantastic work, and your group is certainly a leader in the AI space, for which there's really fantastic and encouraging data. I think it would be great to move beyond contrast, both in MR and CT and a number of approaches. So certainly we need the data, but that's hopefully where we will be moving in the future.
Any final comments from Sabi, AJ, Jonathan? I know that we are almost close to 10 minutes beyond the time, and certainly the crowd is still sticking around despite this being their dinner time. So really appreciate everyone's coming together, and particularly our panelists and Jonathan for you to join us. Had it not been for your jury duty, we would have had you in person.
Absolutely.
But next time we will plan that, and we'll continue to have this exciting collaboration ongoing. Thank you all, and good night.
Thank you. Thank you.
Thank you, John.
Thank you again.